If you're ready to unlock more better days, to take control of your health, to push past your limits and unleash your full potential, then you're in the right place. I'm your host, Dr. Jeremy Bettle. For over 2 decades, I've worked with elite athletes and high performers, helping them optimize their bodies, strengthen their minds, and recover from setbacks. Now I'm bringing that expertise to you through the Vitality Collective podcast. In each episode, we'll dive deep into the science, strategies, and real-world solutions you can apply right away. Whether it's enhancing your physical performance, avoiding or recovering from injury, sharpening your mental edge, or simply feeling your best every single day. With insights from top experts and thought leaders, this podcast is designed to help you take action, feel better, and live the life that you deserve. Welcome to the Vitality Collective podcast, where every day is vital. Today I'm joined by Dr. Belinda Beck, a professor at Griffith University and founder of the Bone Clinic in Brisbane. In this episode, we talk about bone health, covering what osteopenia and osteoporosis really mean, why bone is a living adaptive tissue, and how exercise and nutrition can help prevent frailty. If you've ever wondered what it takes to keep your bones strong and resilient for life, this conversation's for you. Let's get into it. Today, I'm honored to welcome Dr. Belinda Beck. She's coming on the show today to have a really deep dive into bone mineral density and the conditions of osteopenia, osteoporosis, and what we can do about it. Dr. Beck, welcome.
Thanks for having me.
No, thank you so much for coming on. This is such an important topic for me in the transition that I've made from working in professional sport for 20 years and now taking those lessons and applying them into the longevity world. We've had so many people that have come to us who have lived a relatively active life, but have been really steered towards eating and training to be thin, and particularly our female population. And they've come to us with this diagnosis of osteoporosis, having thought they were doing everything right throughout their lives. And it's a frustrating one, and it's a very scary diagnosis for them. So I'm so grateful for you coming on and having this conversation with us, because it just is so important to people.
Yeah, I agree. I hear that story regularly.
Yeah. And so let's dive right in there out of the gate. Why is this such an important conversation with regards to people's longevity?
Well, recently I've started looking at bone health from a very whole of body perspective, because even though, I am a bonehead through and through, I love bone tissue. I love everything about it. It's incredibly fascinating. And I, as a scientist, I just love bone.
Yeah.
However, I do realize there are some other things that we need to survive, and
Yeah.
and including things like cardiovascular health and metabolic health, and of course even mental health. And the common denominator to the health of those things is exercise. Now,
Right.
your frame, your bones and muscles are vital for movement. If your frame can't tolerate the kind of movement you need to keep those other body systems healthy, then you're really screwed. So really, this is the fundamental body part or parts that you need to look after in order to be able to look after everything else. And unfortunately, it's also one of the most forgotten. People do tend to think about muscle primarily for aesthetic reasons and because it's obvious association with strength, but they don't think about bones at all because they're invisible and they're just there and they seem to be inert. If you look at a chicken bone, you think, oh, that's just a thing. It's like a lump of wood. Where nothing could be further from the truth.
Yeah. What an important point that is. We call ourselves we're a strength-based longevity program. Having recognized that avoiding frailty is perhaps the most important thing that we can do to protect all of those other systems. So I appreciate that viewpoint so much. And can you dig into that piece about bone tissue a little deeper, in that it isn't this inert thing, because that's a misconception we come across every day, that people actually don't think it is a changeable thing. It just decreases over time.
Yeah, so there are very few things in the body that are not full of the cells that provide them with they're sort of the maintenance crew and the regeneration crew. I think it's just keratin in your nails and your hair, basically. But everything else has cells that look after them, including bone. So if you were to think about that chicken bone, I'm using that because you could think about your own, but most people have seen a chicken bone.
Right.
All throughout that chicken bone would have been live cells. And they're tiny. They live in little caves in the bone, and joining up those caves are little channels, and they have processes or extensions that go from the cells and join up with each other and form this big connected cellular, what they call a syncytium. So it's this big, if you took all the hard stuff away, there would be this bone-shaped group of cells all in contact. And they're bathed in a fluid, an extracellular fluid, and that's supplied by blood vessels and also nerves, and there's even lymph tissue in there. So it's got the full component of all the things that you need to keep a tissue alive. And the cellular component is so incredibly important because that syncytium is like it's like a sensor. And so when you do load bone, just by standing up, your bones are being loaded, they bend almost imperceptibly, and that bending will force the fluid in the bone past these cells, and that tells them that the bone is bending. And that is actually what is telling the cells that they need to remodel if it's bending too much. So that's essentially mechanotransduction in bone.
That's fascinating. So that really makes it clear then how that mechanism of loading the bone would stimulate the laying down of more of the, I guess, the hard stuff, right? The bone minerals that we would traditionally think of as being a part of the bone.
Yeah. So because, the bone itself is a set substance, it's not movable. You can't just sort of push it out of the way and create a different shape. It has to actually have some cells that will come along that are not part of that syncytium, that network. They're bone cells, but they will come along separately and actually resorb some bone from the place where you don't need it as much and provide the minerals and so on back into the blood. And then other cells will come along and place new bone where you do need it. So, for example, if you were constantly bending a bone so that it was bending like this, your bone doesn't want to be bent that much, so it really wants to be straight. So what would happen is you take a little bit of bone from over here, put some bone here, and in effect, shift the bone over a little bit to withstand that subtly changed force that's being put on it. And you see that happening in fractures. Sometimes you'll see a fracture that hasn't been set properly, or maybe it happened out in the wild and a person has come back in and they x-ray and the bone has actually joined like this. And over time, that will remodel to the, maybe not perfectly, but almost, so that the bone will be its normal shape again. I tell you, this is why bone is amazing to me.
It's incredible, isn't it? And so it will really sort of lay down bone in those direct lines of force that
That's
are being
right.
applied to it, right? Interesting. And so then I think that gives us some clues as to the progression of these conditions that we see creeping in. And so we'll go from, in our youth, normal bone density, and we'll peak, and then we see that decrease in many, many people. And then at some point, you'll get tested and diagnosed as having osteopenia or osteoporosis.
Mm.
How does that happen then? So we're stressing the bone and we're laying down tissue. I guess the opposite is true.
That's right. So as you grow, you develop the bone that will allow you to reach your genetic potential as long as you've got the right building blocks and
Hmm.
stimulus. And everybody will reach their peak sometime between 18 and 30. Younger for women, older for men. The peak bone mass that you attain is largely genetically determined, but as you're growing, there are things that you can do to optimize your ability to get the most bone you can possibly get. After that time, your bone mass sort of plateaus for a while, and how long it plateaus depends on how active you are. And then it typically, in the population as a whole, does tend to drop off. But it's my belief that that is much more determined by activity, how much you're loading your bones, than by age per se. I do believe that we will all lose some bone across life, but if you look at the bones of masters athletes, they lose way less bone than people who are inactive. So that downward trend is much more likely to be sedentary related rather than age related. So the answer to follow up on your comment that the reverse applies in terms of this bone adaptation, yes, if you do unload bone, you will lose bone. Those bones cells that I mentioned, the osteoclasts, will come along and resorb bone if the body perceives it as being unnecessary. I mean, we're basically these highly efficient machines that does not want to be heavier than it needs to be, and so it will get rid of tissue that it doesn't need. And the most dramatic example of that is when astronauts go into microgravity. So the removal of gravity will bring about this massive resorption of bone because there's not a lot of loading on it. Now, they do have good systems in space now where they do loading, particularly to protect muscle and bone for that reason. But the same thing will happen if you're in bed rest. So if you have a traumatic injury and you're immobilized for a long time, the same thing will happen locally if you have a cast on a limb and you have it on for a long time. The same thing will happen if you lose a tooth. So if you lose a tooth and you no longer have the occlusive force of the opposite tooth to press against the bone that the tooth is embedded in, you'll lose bone where that tooth was. So it's a highly sensitive adaptive tissue.
I just love all of that explanation on both sides because I've always likened it to muscle tissue. It's just a slower version. And I think we can, as you alluded to, because we can see and to a certain extent feel the muscle tissue atrophying as we are inactive. I think we just don't get that same sensation with bone density reducing. And can you talk me through some of the classifications then as we see that reduction? What might people hear as they start getting tested?
So the terms that describe the different phases of low bone mass are osteopenia, which is just considered low bone mass, and osteoporosis, which is very low bone mass. These are sort of coined in relation to the T-score that you will get from a bone density test. So the T-score was many years ago, back in 1994, I think, it was determined that there needed to be a number where doctors would say, okay, your BMD is so low now, you need to be on medicine or something to manage it because you are at particularly high risk. And this was determined from big population samples, which showed that at a certain T-score, which is just a standard deviation from average, that when you're that low, you are at a considerably greater risk of fracture. So it's related to risk of fracture. So if you were to have a bone density scan, your score would be plotted against what's called a reference database, a whole bunch of people who have been scanned, and you should be tested against the same race and sex. So you and I would be white, you'd be guy, and I'd be girl. And there is a the plot that we have in our mind of where peak bone mass is on this plot is high, and then gradually it will go down across life, and your score will be plotted against that average line across life. And where you are in relation to that average, aged 20 is what they determine your T-score from. They call it the young normal. So your T-score is calculated from the young normal, what you would have been when you were 20, roughly 20. It's different for different sites, but roughly 20. So it's not age matched. Your Z score is age matched. But the T-score, which is how they define osteoporosis, is matched to what you would have been when you were 20. And this is presumably to give some sort of indication of how much you have lost over your life. So if your T-score is -1 to -2.5, you're considered osteopenic or low bone mass. If you're -2.5 or lower than that, then you're considered osteoporotic.
And what is the distinction in terms of, I guess, relative risk between osteopenia and osteoporosis?
Yeah, that's a really, really great question, because there is really no distinction in that these are really operational sort of definitions for the purposes of doctors trying to determine when they need to treat their patients. Because as soon as you are lower than normal, automatically you have an increased risk of fracture.
Right.
And an interesting fact is that most people fracture when they're with osteopenia. And it's not because they're at greater risk. If you have osteoporosis, you are going to be at greater risk because your bone mass will be lower and it'll be weaker. It's just there are more people with osteopenia. It's purely statistical. So, if you go to the doctor and the doctor says, well, I can't prescribe you medication yet because you've only got osteopenia, and that's because that's what's reimbursed, whether it be Medicare or NHS or whatever. In actual fact, it's much more complex than that, and they would need to consider all the other factors that create risk for that person. And this is why subtly over years prescribing guidelines have changed to the extent that if you have osteopenia and you've already had a fracture, you're considered high enough risk to be eligible, at least in Australia, and I think in the US, for medication. So fracture is the key. Because we can't see inside our bones, that's the most obvious marker. The next obvious is having a BMD scan and seeing how much bone you have. And that takes us down a fairly rocky road, because there are considerable shortcomings of DEXA, because even if you have the same BMD as somebody beside you, you almost certainly will have different risk, because it's not purely BMD that is responsible for that risk. I can talk about that if you want.
Yeah, I think that's a really important distinction to make, because we get a question a lot on, should I go to this facility or this facility to a DEXA because their DEXA is newer, and so on and so forth. And then we have other people who use the bone score test as a test of sort of hardness of the bone. And I think it's really important to make this distinction on sort of the quality of the bone as well as the mineral density. As Stu Phillips was telling us about the high level of protein that's contained in bone, because if it was just bone density, it would be like a stick of chalk. So you'd have a lot of minerals, but then it would just be very brittle. So I'd love for you to sort of outline, first of all, how do we get scanned? If you could tell us a bit more about the DEXA, and also what are some of the other factors that we would need to understand to get a true sense of our risk?
Yeah, so this is a very fraught area, and it's constantly moving. I suppose the first thing to say up front is, for all practical reasons, DEXA is what we've got. It's the most recognized, it's the most available, it's the most understood by doctors. It's what the T-score is based on. It's what prescribing is based on. It is relatively precise. So it's quite, you can get the same score twice in a row from it. So notwithstanding its sometimes considerable shortcomings, it's really still what we have. The most important thing, if we are talking about using DEXA, the most important thing is if you are tracking your BMD with DEXA, that you go to the same place and be scanned on the same machine for as long as you can. Eventually, that place will have to replace the DEXA, so you will have to get a different one. But we've even done that at our clinic. But there are ways that you can get around that, get around the problems that creates. But if you can, you must get your DEXA on the same thing, because you just can't compare scores on different ones. Now, the larger question is, what are our alternatives to DEXA? And there are many. Probably way back, turn of the century, we started looking at ultrasound. And the most common way to do that was looking ultrasound of the heel. The great thing about these ultrasound machines is that they were small, they were cheaper than DEXA, they're portable, no radiation. You could scan kids with impunity and not be worried about ionizing radiation. They were okay. They would give you an indication of what your bone health was, but the problems were they weren't actually very precise, so you wouldn't necessarily get the same score. There's quite a lot of variation in score. And also they only scanned the heel. And of course, the clinically relevant sites are spine and hip, wrist and so on. So then we started talking about the fact that bone shape is very important to bone strength and bone size. And DEXA has a horrible practice of overestimating your BMD if you're big and underestimating if you're little. So along came PQCT. Now, you can test on CT, computed tomography, but it's quite high radiation. So it's not a very good population-level screening tool, and it's quite expensive. So a company developed a peripheral quantitative computed tomography machine. So it's a small, if you'd seen a CT, they're like a big donut. This PQCT is a smaller donut, way, way less radiation, very, very low, even lower than DEXA. And on that, you could scan the end of your forearm and your leg, the portion between your knee and your ankle, you could scan there. And with that, we're actually able to parse out the cortical bone and trabecular bone. We could also see the shape of the bone and the width and the thickness of the cortex and all of those things that are very important to the strength of the bone. And this is good for research. It helps us. We could also look at muscle size and density, all sorts of things. So it was a great research tool, but it's never been really adopted into the clinical space. So nobody has them in their radiology clinics, and doctors don't know how to interpret them. They're quite time-consuming to analyze. So it's never really rolled out into the clinical space. The other thing that's problematic with them is the resolution isn't very high, and again, they're not able to scan spine and hip. So along came high-resolution PQCT, which is an even better research tool, horribly expensive and much less likely to be in a radiology clinic. So more fabulous research data, never going to be accepted into regular clinical space. And then finally, most recently, along has come REMS. Now, this is another form of ultrasound, but it has been developed to be able to scan the spine and hip. So it's overcome that problem of only scanning the heel. It uses a different methodology to create a score. And whereas the ultrasound of the heel looked at speed of sound and related that to the strength of bone, this REMS tool, and I won't make you all go to sleep by explaining exactly how they get BMD, but it does produce BMD. And unfortunately, ultrasound does not measure BMD. So they have to, there's a bit of magic between the end of the ultrasound transducer and what you get on the piece of paper.
Right.
Right now, that is being marketed as the revolution in measuring bone. Fortunately, I think it's a bit early days, and there are many people who are questioning its validity for a number of reasons. So I think that's a watch this space. If it works, it will be fantastic because it is portable. It's quite expensive, but it is portable, and there's a lot of ultrasound gel used. It's just like
Right.
if you have a scan on your stomach when you're pregnant, there's a whole bunch of gel on your stomach.
Right.
But it would actually change things up a bit. So we're just watching this space, though.
Yeah. And have you heard much about the bone score? It was a technique developed at UC Santa Barbara that we've used on a couple of clients in conjunction with the DEXA. Can you tell us a little bit about that?
Sure. So I mentioned trabecular and cortical bone, and I don't think I described what they were. So when you think about that chicken bone I was talking about before, so it's a long shaft and then slightly expanded ends. Typically, if you were to cut that shaft in half, you would see it's a cylinder, and the outside of the cylinder is made of compact or cortical bone, very, very dense, very, very strong. That's what all our long bone shafts are. Also, all the outside of all of our bones is compact bone. It's thin in some places, thicker in others. But in the big, large, expanded areas at the end of bone, in the middle of the vertebral bones, all the big spaces is trabecular bone. That trabecular bone is also called spongy bone because it sort of looks like a sponge. It's got lots of beams and struts, interconnecting struts. So it's a big mesh, and all of those beams are aligned with the primary loads that are put on them. Those that trabecular bone has, because it's got sort of beams and struts, it's got a very large surface area. So it is very, very susceptible to resorption. So it is often highly affected by things that can cause osteoporosis, like steroids and so cancer chemotherapy. And so that can reduce considerably. And when that does reduce, it really has an effect on the strength of the bone. So sometimes it can reduce to the extent that, say, a beam will become thinner, but a strut that goes between them can resorb completely, and the strength of both of those beams will be considerably less, more than just by reducing that amount of mass, because they no longer have the interconnecting beam. So trabecular bone score is really important because it can actually look at that and detect those changes that DEXA normally can't. The fact that they have come out with a trabecular bone score is actually very useful. It does give more information because, as I was saying before, two BMD scores that might be equal do not give you the full story about that person's risk, because one of those people might have had a whole bunch of those interconnecting struts resorbed, and that person is at considerably greater risk of fracture than the other person. So yeah, really nice to get trabecular bone score if you can. It's not always available. It is quite expensive, so not every radiology clinic will have it available to analyze.
Yeah, we used it in conjunction with the DEXA and found it to be quite informative with a couple of our clients who came through. And so then now that we have a bit more of an understanding of the progression and the fact that bone does adapt one way or the other, let's talk a bit about how bone responds to training. You gave us a bit of an overview there. This has become quite a hot topic on social media. And I'm seeing a lot of MDs, a lot of trainers seeing the research that's coming out on, jump training is a big one. Lifting heavy is a big one. And there seems to be a jump right to, like, this is the thing that you want to do. Can we just start off with a bit of a grounding in in how bone adapts to the forces that are applied to it.
Yeah. So, as I mentioned before, it's really all about bone bending and the fluid flow that is generated because of that. Because it's that fluid flow that is shearing past the cell membranes that is telling them that the bone is moving. And if that shear is really is high, then it's telling them it's moving too much and you need to do something to avoid this. One or two episodes of that a day, maybe you jolt down from a curb, that's not going to cause the bone to completely remodel. It's it'll cause probably a little bit of micro damage, and that will be mended. Another fabulous thing about bone. You have to tell the cells more often than that this is the kind of bending it's going to be exposed to chronically if it doesn't change itself. So the bending of the bone is the stimulus. Now, that is the reason why just doing the same thing that you always do is not going to change your bone. In fact, in some cases, just being the same amount of active as you've always been is not even going to prevent the loss across life unless that your level of activity is very high. So, for example, walking or doing more walking is not going to improve your bone mass because your bones are not going to be bending any more than they normally do. So there's no stimulus there. Swimming, same thing. There's something about weight bearing that bones need to feel. Not only is the movement of that fluid past them and the amount of movement important, but the speed of movement. So rate of loading is also important, and it's one of the reasons why we use impact as a stimulus, because an impact applies a very fast rate of loading. You just have to be careful. I always put the caveat in there for people with osteoporosis. There's ways of doing that are safe.
Yes.
So that is that's the reason why we need to overload bone to make it adapt. So you need to do something more than you are currently doing in an exercise sense to be able to adapt. Now, if you have an Olympic lifter, muscles like iron and fit as a fiddle, it is highly unlikely that you are going to be able to improve that person's BMD with exercise. Their bones are already as adapted as they're ever going to be because they have already given those signals to the bones. And unless they can keep lifting more and more weight, which is physically not possible, their bones are just going to say, okay, right, we are strong enough. We can put up with any load you put on us. We're not going to get any more. But the point is moot because they don't need to be any stronger. Most likely they've got fantastic bones and they're good. So you can work on their heart health and maybe their mental health for whatever crazy reason they feel they need to do that about
lifting. Feel called into that sport, right?
That's right. However, if you have, and I'm thinking of the most frail version, a 95-year-old woman who hasn't lifted anything heavier than a teacup for the last 50 years, then that person will have very frail bones and virtually anything is going to bend them enough to cause a stimulus. So this is what we talk about, the initial values principle. The lower you are, the more you are going to adapt because the cells are going to sense the stimulus faster and more strongly. But the same thing can be said for someone who is, you mentioned this right at the start, they may think that they've done everything good for their bones throughout their life. They've eaten healthy and they've done a lot of exercise, but perhaps they're a marathon runner. Mm-hmm. So maybe they started training when they were in their teens and they've been running miles and miles and miles their whole life. Now, their bones would have adapted to the running stimulus in their teens, and they have not been overloading their bones ever since. So all they've actually been doing is perhaps creating a bit of micro damage from the constant footfalls And so the bones have been having to replace that micro damage and resorb and rebuild. That sort of remodeling will have been happening. Sometimes that happens to the extent that they develop bone stress injuries, but many times people can tolerate it. And also, oftentimes when people are doing that amount of physical activity, they have an energy imbalance. And I'm sure I'm not telling your listeners anything when to say that that energy imbalance is really bad for bone. It causes sort of a drought condition, and in a female that causes a reduction in circulating estrogen. You take away inhibition from osteoclasts, which is what estrogen does, and they will start resorbing more bone. So, I'm not saying that running is inherently bad. It's great for many people, but you must maintain an energy balance so that you don't go into those drought conditions or starvation conditions, and to keep your bones strong. And don't think that that running is going to be making your bones any better than they already are, because you're not overloading them.
Yeah, this really hits on a couple of my pet peeves when it comes to bone. We're seeing people all over social media, walking on treadmills in weight vests that weigh like 3, 4, 5, 6 pounds. And I think the thing I want to highlight from what you've said there is that it isn't just loading the bones, it's overloading the bones.
Right.
And this is something that we try and emphasize with muscle as well. Your yoga, your Pilates, your walking, your running, it gets you to a level. You will adapt to that level, but then what? Right? If that's all you ever do, you'll only ever be at that level of strength.
Right.
If you're not stressing the muscles, you're not stressing the bones. And so we really need to make sure that there's an overload, and we continue. So we try and emphasize that lifting heavy basically means lifting more than you are capable of at a certain time, and increasing relative to what you can lift, and just continuing to progress. And, we had a really proud moment with one of our 82-year-old women. She went for her first DEXA since we started, and saw her first ever increase in bone density. She got 3% of the spine and 5% in one of her hips.
How great
And
is that?
just incredible. But it was precluded around, I think people had treated her like she was so delicate,
Mm-hmm.
and wouldn't let her progress weight. And so we very, very gradually and very slowly and safely built her up to where we created a good foundation. And we started her deadlifting, and she's now deadlifting 50% of her body weight, and she's doing 12 to 15 reps with that. And we've started her on some plyometric training, and again, safely introduced that into her program where it didn't actually cause the injury that we're trying to avoid. And lo and behold, 9 months later, and she's had a big increase. She's still in that classification, but she's adapting at 82 years old. And we
Welcome
were
to my world.
incredibly proud. Yeah.
I know. That's why I get out of bed in the morning, because that's what,
Yeah.
that story repeats itself every day in the clinic.
Yeah.
It's fantastic, and, so healthy. And I bet after a point, she kind of forgets about her bones and just starts thinking how amazing she's feeling because she's so strong and all the stuff she can do again.
Well, because that's the other side of it, isn't it? There's the bone density piece, the fracture risk, but then there's also the fall risk. And the thing that I think has given her the most confidence is we actually work on the plyometric ability of catching yourself if you trip. And so her ability now to prevent herself from falling, which she's done now several times, walking on the street in Manhattan, she's caught her toe on the sidewalk there and hasn't fallen. And I think there's that side of it where, seriously, now we're thinking about, okay, we're going to rehab this shoulder and get a hamstring rehabbed, and just keep her progressing as she can, and not think, oh, she's 82, we've got to wrap her in cotton wool.
I mean, it's crazy. And I say this all the time. Old people are just you and me a little bit later. It's not like suddenly we turn into fragile little creatures. We still are able to do stuff. And yes, we get a bit tired, and, it's going to happen to all of us.
Yeah.
I would much rather be that person who can go out and carry my own shopping than,
Yeah.
be sitting in a armchair in an aged care facility being fed soup.
Yeah. I mean, can you think of anything worse? And then I think the quality of life, we use the term vitality, but the quality of life that you create for people in giving them that strength and the ability to continue playing their sports or doing their activities that they love. I think, that's the byproduct of the focus on bone health, is that
Yeah,
we get that by training for all the other stuff.
that's right. And, when push comes to shove, really, all any of this therapy, exercise therapy, is about is quality of life. I would say that many of the people who come to the clinic are actually coming to hang out with their mates in class because it's a
Yes.
social activity.
Yes.
And, it's, I don't even care why they're coming. I just want them to come and feel better, get stronger, stay
Yeah.
active, be a functioning member of the society, enjoy your grandchildren, you know.
So with that messaging, of overloading the system, with the prevalence of, okay, this study on social media is being presented as, okay, start jump training. I do just want to touch on the risk of starting too aggressively.
Yeah.
What do you think that, in terms of the starting point? I'd just like to give people some sort of guidelines on where to start. Because I know, like, with perfectly healthy young athletes, I wouldn't start day one with a plyometric training program.
No.
We would build a foundation to work up to that so that we don't cause injury.
Yeah.
How do you think about that?
Well, the way I think about it is that I have a licensed program that I train people how to do that for individuals, and you make sure that you've got somebody supervising you and
Yeah.
teaching you as an individual, because every single person is going to be starting at a slightly different level, and it's not just where they start. Something may happen, um, they may be they may have had a fall and then they come back to class again, and so you have to completely regress. You can't stay at the
Right.
same level all the time. It's very much a cycle, but that supervision by an expert is key, particularly for someone who has never done very much. So
Yeah.
we have some people who can't even touch their finger to their nose. They have no body awareness
Hmm.
whatsoever, and so you're actually teaching them where their limbs are in space.
Hmm.
So
Yeah.
it varies from an elite athlete who, mind you, don't necessarily have good balance, right through to the
It's
extremely
true.
frail 95-year-old. And the other thing that I meant to say before, when we were talking about keeping people active and doing the things they love, there's a very big difference between somebody who has been playing golf all their life and they come and see me and say, "Oh, you've just said that I can't do deep forward flexion and I shouldn't do fast, rapid twisting motions. Do I have to give up golf?" And I feel like saying, um, well, I normally do say, "Do you want to give up golf?" No, I don't. I love it. Well, don't give up golf, for goodness sake. You've
Yeah.
been doing it for 40 years and it hasn't hurt you yet. I wouldn't give it up even if I just discovered I had osteoporosis. Keep
Right.
doing golf, because if you do give it up, you are not going to be able to start it again. But
Right.
the difference is, if somebody comes to me with osteoporosis and says, "Well, what should I do? What should I start? Should I take up golf?" It's no. You
Right.
definitely should not be taking up golf. That
Yeah.
is going to create a fracture. So the answer of the kinds of activities that people should do and they're safe to start at is absolutely individual.
Hmm. Yeah. I can't emphasize enough a couple of points you made there. Having an expert supervise you, often that person is not your doctor. That they
Correct.
won't have any training in physically preparing the body. They will be able to help you on the medical side with the medications. But when it comes to this sort of work, I think there's there's a couple of frameworks we like to use from, okay, are you in pain? If yes, we probably start with a physical therapist or a physiotherapist. If no, you're just weak and frail, I think there's still a call for a PT, but then progressing into personal training and strength and conditioning coaches who have actually guided people through this sort of problem, or a person certified in a licensed program like your own, where they're an expert in this field and can safely progress you from one step to the next, knowing when it's appropriate to make progress and overload the system. I think when you've made enough progress that you can take a leap to the next stage is very, very important.
It absolutely is. And knowing how to do a proper evaluation on somebody and to recognize some really important issues. The first one that comes to mind with postmenopausal women is pelvic floor. Just if someone's just had pelvic floor surgery, you need to treat that person with kid gloves. I'm not saying don't do anything. They absolutely need a sort of a lifting program, but you absolutely need to be careful with them, because if you blow out their pelvic floor again, they are not going to be thanking you. And that is a quality of life issue that is very, very important to postmenopausal women, and many of them. So frozen shoulder, if it's not just any old shoulder problem, frozen shoulder can be a long-term pain in the neck thing that will bother them in virtually everything they do outside of the gym. So there are being able to recognize some of these, all of these other conditions, heart conditions, being aware of the increased blood pressure, glaucoma, all of that stuff. If you're talking about heavy lifting, you need to be across that stuff, and that's what your training is for.
Exactly right. And sort of knowing the order in which you're checking these things off, I think, is very important. If we get somebody who needs the pelvic floor work, yet they might have come to you and say, hey, I just got this diagnosis of osteoporosis. I need to take care of this. But you sort of have to understand the process of getting to that. Right? We can't safely, and this was the case with our lady that we worked with. She had other stuff going on first, to where actually a couple, maybe even 3 months in, she was like, Jeremy, we're not doing enough to affect my bone density. Like, right, because your hamstring still hurts and your shoulder you can't lift your arm over your head. So we can't get there yet. And yet once we resolved that stuff, we could then accelerate quite quickly. But I think she'd been stuck because there's always a focus on, okay, well, let's start jumping today.
Yeah.
Right. Bone density today. And that it's a slower process.
Absolutely.
Breathe. This is not next week. Right.
And kudos that you were able to fix the shoulder and the hamstrings. I mean, well done. I suppose there are some of the other conditions that you need to be careful of are those in autoimmune and inflammatory conditions. Don't fire up somebody who's in chronic pain. How I said, sometimes people will come in and you have to regress them. Maybe someone's got rheumatoid arthritis and they can't even grip a bar that day. There's you have to be aware of that and constantly monitoring them and listening to their feedback. Don't ignore it when someone says, no, I think we're progressing too quickly. If they're feeling that, then you listen to them. This is, speaking of marathons, it's a marathon, not a sprint in terms of improving people. Even in the oldest old, it's still something that needs to be taken slowly.
Yeah, and that's actually the conversation I had yesterday with this individual. Was she had something going on, and so we completely changed her program. And I was just explained to it, it's not about feeling perfect every day. It's about making some progress every day. And so if you're feeling like this today, we can still do something, but we can't do what we've been doing. And so I think just taking that view of being adaptable, it's one of my favorite parts about being out of sport and working with this population now. You're tested on all of these fronts every day. And it's quite rewarding work, but but it's quite complex and requires a lot of focus and a depth of knowledge.
Yeah, it really does. And, when we're doing our clinical trials, we can afford to be a little more aggressive. We recruit based on certain screening criteria so that we don't take on people who have pelvic floor problems or, some frozen shoulder for the last 4 years.
Yeah.
So we can afford to be slightly more aggressive and, push people. But in the clinical setting, we are absolutely guided by each individual, and we take it way, way more
Yeah.
slowly, because if you cause a fracture, some cause an osteoporotic fracture, they are 4 times more likely to have another one. So you don't want to
Yeah.
start that cycle.
That's our whole principle behind avoiding frailty. If you get hurt and you're sidelined for 3 months, as you alluded to, if you're on bed rest, or often it'll be they're sat in their chair for 3 months, it's every system that downregulates,
Every system.
plus your social connection, plus all your cognitive systems. And so we accelerate that by causing the injury. We can accelerate that drop so fast that
Yeah.
the primary goal is avoid injury
Mm-hmm.
and avoid them getting hurt doing their sport. And I also love the fact that you brought up the energy availability piece, because that was one of the other things that we worked on. She's very small framed and, has been very controlled with her diet over her life. And so we increased her protein intake and all the other factors that go into that to really help her avoid those situations where she's straining muscles and getting fractures and things, just general energy to be able to perform these functions, I just think are absolutely critical.
Yeah. Yep, for sure. It's that there's a lot of psychological aspects that when we start talking about diet and particularly associated with presentation sports, figure skating and gymnastics and those sorts of things, where it's important to be very lean. And even with runners who want to be very lean so that they are not lugging a very heavy body around a marathon course. So they often do have to fight to get through this barrier, this mental barrier. If I eat this, I'm going to be too heavy. And in actual fact, by eating this, it's going to keep you on the field or on the mat or on the road.
Yeah.
Otherwise, you're going to be injured.
Yeah. Yeah. And I just look at the pressure that society puts on women in general in this regard, where the goal that you might have of avoiding frailty through increasing muscle mass and bone mass, it is directly counter to what you're being pressured to do, which is be in a calorie deficit basically all the time and do a load of cardio work. So to exacerbate almost that calorie deficit. And so that's been a big challenge, is that psychological piece here of unwinding that messaging. And it has been so difficult for a lot of people I've worked with to even think about, even consider bringing their calories up, because that fear of gaining weight, even though they're telling you they want to gain mass, but I don't want to gain weight.
It's the same thing.
Yeah. I don't know how we're going to do this.
It's physics.
Yeah. You might end up weighing more if we add 5 pounds of muscle, right?
Yeah, and that's a great thing. When I look at the results from the clinic, and because we do whole body scans so we can look at lean mass, and of course we also measure height and weight goes up a little bit, but so does lean mass. And so this is they're gaining weight because they're gaining lean. Their percent fat is coming down, but I don't tend to focus on that because I don't care about fat. But I can tell you the number one thing that these women look at when they have their whole body scan is their fat.
Yeah. Well, and for us, just getting over that one number on the scale. We've sent people for DEXAs, we've sent people for all sorts of different body composition measures so we can show them how the composition is changing in a positive way. But if that number moves 1 pound, oh my gosh, it's tough. Like
Yeah.
in that first 3 month period when we're adapting, it's really challenging.
Yeah, that's been a lifetime of brainwashing, Jeremy. I'm a
Yeah,
living, breathing example of
yeah,
having that impact. Yeah, it's
yeah, yeah.
very, very tough.
And so, how do you overcome some of that with the people that come into the clinic?
Well, we do have a dietitian on hand,
Hmm.
and she has a 45-minute consult with every single person who comes in. And you can imagine with our average age client is early 60s. So these are people who have been eating pretty much what they want to eat established for probably the last 30 years, and
Yeah,
they're not of a mood to change
right,
irrespective of their body type. Most of them want to lose a bit of weight. um, Many of them are vegetarian, quite a few of them are vegan, and we just say we think that we can help you with some of the best way, the healthiest way to get some more calcium and protein into your diet. So it's worth just having a chat. They normally come out and go, well, I did actually learn something there. And yeah, I didn't realize that having this milk instead of that one would be a much more effective way of getting my calcium.
right.
And oh, I didn't realize that if I ate this particular thing at the same time as that, I wouldn't be absorbing any of the calcium out of that. So there is a lot to be learned from an expert dietitian to actually
Yeah,
optimize your intake of these important nutrients. And there's no getting away from it. Calcium, vitamin D, and protein. Calcium, vitamin D are the two main bone ones, but protein
right.
is also extremely important. And so even though there are a zillion micronutrients that
Hmm.
come and go, but once they come, the supplement companies basically start marketing and telling us what people need. So having these
Yeah,
monster doses of vitamin K2 and magnesium and zinc and boron and
yeah,
all the other things there's no evidence that more
right,
than just your diet, your normal a balanced diet of these nutrients is doing anything for your bones.
right.
So just it's the usual recommendation: eat a balanced diet that is heavy in vegetables. Make sure you get enough protein. Try to minimize sugar and fat. Eat plenty of fiber, and you're all good.
Yeah, it's pretty much the messaging, isn't it? I tell you what, though, if we didn't have those principles, we'd be making a hell of a lot more money. If I could sell you 10,000 times your daily recommendation of K2, I'd be doing all right.
Absolutely. And I try to. You have to be careful talking about evolution sort of broadly with everybody, but I do try to make people think about how we evolved. And I can tell you, we didn't evolve taking a gazillion times what we need in one particular mineral. And we have no idea how that interacts with all the other things in our body. It doesn't make any sense. Food
Yes.
first,
Yeah.
always. That's our
Yeah.
mantra. And quite aside from anything, in the nutrition world, they're discovering that the food matrix, what these nutrients are sitting in, is
Yes.
so
Yes.
vital. So eating food is so much better for you than
Yes.
eating either a supplement or that terrible refined stuff you see on shelves that is, they call it food, but I'm not quite sure what it is.
Yes.
Uh,
Food.
yeah. And so just get food, eat food.
Yeah. 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 It's a comment I made the other day. Michelle and I were talking, and it was just that humans through time have performed really well in such varied conditions. There can't possibly just be like a way to do this,
Right.
right? You can't possibly need to have this supplement to thrive. When you look throughout our history at conditions in which we've basically been Olympic athletes, chasing down our food, right? We've done pretty well under a whole host of conditions. So that's a whole different sideline we could go down.
It is, but I 100% agree with you. And also the body is remarkably resilient to not having certain things consistently. So, the daily supplement, give me a break.
Dr. Beck, I want to respect your time because I know it's early in the morning there and you haven't had your cup of tea yet. Right. So we always end with 3 easy things that people can go away if they're just starting out. Your 3 takeaways from today that people could pick up and start running with right away.
For their bones?
Yeah, for their bones.
Okay, well, let's assume you're average Joe. Just try to do more movement and make that movement more intense than you're used to doing. Listen to your body. If you feel pain, listen to your body and stop doing what it is that's causing the pain and see somebody about it. And then make sure you provide your body with the building blocks to build bone from that movement that you're doing.
Amazing. I just love those so much. And Dr. Beck, tell us a bit about your program. Where might people be able to find you, people who are licensed by you, and maybe be able to work with you or one of them?
So, I am a professor at Griffith on the Gold Coast, but my clinic, the Bone Clinic, is based in Brisbane. And this is where we continue the research, and we have implemented ONERO, which is the exercise program for bone. Because there's only one bone clinic, we did license ONERO. And so if you just type in ONERO locations in Google, it will come up with the map. And the map will have all these little tags all over it for all over the world. And you can zoom in on those tags for where you live. Click on the tag and it will drop down the details of the licensee.
Amazing. And can we find you on social somewhere?
Yes. Well, if you search for the Bone Clinic on Facebook or whatever it's called these days,
right.
Such a dinosaur, that's where I put most. I post a lot of scientific stuff there. I try and put it in lay terms, but that's a really good way to keep up to date with what's happening. I am on LinkedIn. I don't really do very much there. So, right. Yeah. Facebook for the Bone Clinic stuff and for bone stuff. That's probably the best place. But look for the Bone Clinic.
Beautiful. Well, Dr. Beck, thank you so much for this. It's been absolutely wonderful. There's a treasure trove of information there for people. We really appreciate your time.
My pleasure. Lovely to chat.
What a powerful conversation with Dr. Belinda Beck. Here are 3 things that you can take away from today's episode. Number 1, try to move more and make that movement more intense than you're used to doing. Overload is the signal that bones need to adapt and get stronger. Number 2, listen to your body. If you feel pain, listen to your body and stop doing what it is that's causing the pain. Protecting yourself from injury is what ensures long-term progress. Number 3, make sure you're providing your body with the building blocks it needs. Exercise alone isn't enough. Nutrition completes the adaptation process. If today's conversation resonated with you and you're ready to apply these concepts into your own life, that's exactly what we do at Vitality Collective. We bring together world-class diagnostics, personalized planning, and ongoing performance coaching to help you build a life of sustained vitality. Head over to www.vitality-collective.com to learn more. I'd like to ask a quick favor. If you've enjoyed this episode, please follow the show, rate it, and write a review. It really helps us reach more people who can benefit from these conversations. You can also share this episode with someone who you think would enjoy it. Thanks for listening, and we'll see you next time.